In our previous video, we have seen about the definition, types and the termination of tubal gestation. So, in this video, we will see about the clinical features, investigation and management, that is the treatment of ectopic pregnancy. First, the clinical features of tubal pregnancy. There is a classical triad of symptoms seen in ectopic pregnancy, which are amenorrhea. There will be a period of amenorrhea, there will be abdominal pain and vaginal bleeding. This is a classic triad of ectopic pregnancy. And the other symptoms include fever, vomiting, syncope, cardiac arrest, weakness or dizziness. These are all the symptoms. Coming to the signs, if there is rupture of ectopic pregnancy, there will be signs of shock like hypotension and tachycardia because of profuse bleeding. And the signs which are suggestive of ectopic pregnancy include abdominal rigidity, there will be involuntary guarding, severe tenderness and evidence of hypovolemic shock, which include features like hypotension and tachycardia, cold clammy skin, etc. Then there will be abdominal tenderness on palpation, and on vaginal examination movement of cervix causes or aggravates the pain. This is seen in about 75% of the cases, and also there will be a bulge or fullness in the posterior fornix of vagina due to collection of blood in the cul-de-sac after rupture. And in case of ruptured ectopic pregnancy, in acute cases, the patient will be in a stage of shock and she can even collapse due to intraperitoneal hemorrhage. So, what are all the differential diagnoses for ectopic ruptured? So, the differential diagnosis would be torsion of ovarian cyst or torsion or rupture of any abdominal viscus, or rupture of corpus luteum cyst, and acute appendicitis. These are all the differential diagnoses for ruptured ectopic pregnancy. And in case of subacute or chronic cases, there will be a history of amenorrhea with attacks of abdominal pain and bleeding. So, they may suggest threatened abortion, but here in case of ectopic pregnancy the pain will be more severe. And on palpation there will be a tender adnexal mass and diagnosis will be based on ultrasound. And in some patients laparoscopy could be both diagnostic and therapeutic. These are all the clinical features, that is the signs and symptoms of ectopic pregnancy. Coming to the investigations. The investigations first would be urinary pregnancy test. Next is ultrasound examination. In ultrasound examination, transvaginal sonography can alone be used to diagnose in more than 90% of the cases. So, in USG there will be absence of gestational sac in uterine cavity. It should be seen in the fallopian tubes. So, the uterus would be empty and there will be adnexal mass which is separate from the ovaries. So, this is the investigation. Now, coming to the management. The management of tubal pregnancy could be either medical or surgical. In ruptured ectopic pregnancy, surgery is the only option, whereas in case of unruptured ectopic pregnancy, medical management can be advised in certain cases. Now, let us see about the surgical treatment. Surgical treatment would be salpingectomy, is removal of the fallopian tube, or conservative preservation of the fallopian tube. So, when the ectopic pregnancy has ruptured and the patient is in shock, the treatment is immediate laparotomy and salpingectomy. Whereas in selected cases we can perform conservative surgery which increases the chance of future uterine pregnancies. And this conservative preservation includes salpingostomy or salpingotomy, which is performed when the pregnancy is usually less than 2 centimeters in length and it is present in the distal 1/3 of the tube. Then we can also do segmental resection and anastomosis. All these are conservative methods for preservation. Next is the medical treatment. The medical treatment is the drug of choice being methotrexate. Which is a folic acid antagonist. The indications for methotrexate are: the patient should be hemodynamically stable, with no signs and symptoms of active bleeding. And the size of the gestational sac should be less than 4 centimeters, and there should be absent fetal cardiac activity. And beta HCG levels less than 5000 milli-international units per milliliter, and the patient should be willing for regular follow-up. Only in these cases the medical treatment with methotrexate is indicated. And some of the contraindications are beta HCG levels more than 5000 international units per liter, presence of fetal cardiac activity, presence of free fluid in the cul-de-sac, hypersensitivity to methotrexate, immunodeficiency states, the patient with liver disease or peptic ulcer disease or any active pulmonary diseases, and if the patient is anemic or has blood dyscrasias like thrombocytopenia. All these are contraindications for methotrexate therapy. Coming to the dosage, methotrexate can be given as single dose therapy, 50 milligram per meter square of body surface, deep intramuscular injection, or it can be given in 4 doses, 1 milligram per kg body weight on alternate days, or multiple doses of 1 milligram per kg intramuscularly on days 0, 2, 4 and 6. All these regimens are equally effective. So these are all the important points about the clinical features, investigation and treatment of tubal pregnancy. Thank you.